And the first debate is asymptomatic hyperuricemia should or should not be treated. And for the motion, Dr. Udalak Chakravarti will be speaking, and for against the motion, Dr. Biswajit Bonik. So I am asking first Dr. Udalak Chakravarti to speak in favor of the motion.
So, very good afternoon, respected chairpersons and dear delegates. Today I would like to speak in favor of treatment of a condition known as asymptomatic hyperuricemia. So, my motion is it should be treated. So, this is a brief history about the journey of uric acid. This panel is very commonly known as the doyen of hyperuricemia and gout. On the contrary, this panel is comprising of Frederick A. Mohammed. This physician is less known because he was the first person who told that hyperuricemia may be linked to hypertension. And this raised many eyebrows around the world and opened a new real avenue for cardiovascular risk and hyperuricemia. The problem of hyperuricemia is that there is no universally acceptable definition. There is no global consensus in defining hyperuricemia right from the beginning. The causes are plenty. I am not going into details of any of the causes. Well, if we take a look at the epidemiological data, in the Enhanced 3 and Enhanced 2007 and 2008, we can see in the US there is a marked rise in the prevalence of hyperuricemia in US. The causes were attributed to obesity, alcohol, lifestyle changes, and many other causes. On the contrary, a cross-sectional study of health insurance claims database from Japan showed that only 2.6% of the asymptomatic hyperuricemia prevalence among 2.95 lakh population. The answer was given by the Japanese physicians who preferred to treat asymptomatic hyperuricemia compared to the US physicians. So there is a clear-cut discrepancy between Japan and US in treating the same. The Indian data followed, which has shown the hyperuricemia has been an increasing prevalence, especially among the obese, the diabetics, and hypertensives. Now, the famous oxidant-antioxidant paradox of uric acid. Some experimental studies claim that uric acid is an antioxidant because of its nature of preventing lipid peroxidation, but it is heavily limited to this property because it is only in presence of ascorbic acid and thiols, and only extracellular urate is capable of doing that. Several experimental studies and animal models have proved that uric acid is rather a pro-oxidant because of its superoxide dependent mechanism of increasing oxidative stress, leading to endothelial dysfunction and a pro-inflammatory state. This is the proposed model for urate-induced oxidative stress via ROS. Now, we are speaking about this stage. This is asymptomatic hyperuricemia because it can be divided into two stages. First one is stage where there is no crystal deposition and the patient remains asymptomatic, and the second one is the stage where there is crystal deposition without any symptoms. So we are worried about the potential clinical consequences regarding the non-crystal deposition disorders of soluble uric acid, which may lead to cardiovascular complications, CKD, metabolic syndrome, and cerebrovascular disease. So you can see when you talk about hyperuricemia, we are very much aware of this bomb which is about to explode or has exploded, that is gout. What about a bomb which has a timer on it and has yet not exploded and you are not even aware of it? The pathophysiology of gout does not really come to the ambit of my talk today, but majority of the patients suffering from gout are under excretors rather than overproducers of uric acid. So the first study was a normative aging study which proved the incidence of gout was directly linked to the degree of asymptomatic hyperuricemia, but we all know that all patients with asymptomatic hyperuricemia do not develop gout. The answer to this disparity was given by Degan et al. They developed a risk score on the basis of association of 3 genetic loci and the concentration of risk of gout. But if we cannot predict the first occurrence of gout, is it beneficial to treat, to prevent the first occurrence of gout? Unfortunately, yet now we do not have that robust evidence to prove. There has been a definite association between hyperuricemia and nephrolithiasis, and urate-lowering therapy has been shown to be beneficial in lowering the risk of nephrolithiasis in patients. This is the most uncontested and undebated indication of treating asymptomatic hyperuricemia, that is, patients receiving chemotherapy for leukemia and lymphoma. Allopurinol has been a revolutionary drug for this, and many studies have proved the efficacy of allopurinol in preventing this acute urate nephropathy. Now the concern of the hour, cardiovascular disease and hyperuricemia. The guidelines and evidence both are in opposite poles. The opinions and facts are running haywire, and there's lots of controversies on that. What is the link between hyperuricemia and hypertension? This is a proposed two-stage model of blood pressure increased by hyperuricemia due to suppression of nitric acid, proliferation of vascular smooth muscle cells, platelet adhesiveness, and many other causes of endothelial dysfunction. So, as far as evidence is concerned, these studies have showed the effect of allopurinol on blood pressure, especially in lowering the systolic blood pressure, which was around -6.3 in the patients who received allopurinol. And hyperuricemia has been established as an independent traditional risk factor for incident hypertension as well. Now, there was a very big controversy regarding whether hyperuricemia is the cause of hypertension or it is the reverse. But this was answered by the Bogalusa heart study, where they have shown that childhood uric acid was a novel predictor of increased blood pressure in adults. Now, the risk of atherosclerosis was also increased in hyperuricemia in many studies, where they have shown an association between hyperuricemia and increased carotid intima media thickness, as well as the increased risk of coronary artery calcium score. Now, this was the meta-analysis which was legendary in its own, because it compiled across 28 studies and 4 lakh population, where they have shown that association of hyperuricemia with coronary heart disease was around 9%, and on the contrary, association of hyperuricemia was also associated with a 16% increase in overall mortality. The ENHANCE study was one of the largest study linking serum uric acid to mortality and cardiovascular mortality, which has proved that increased serum uric acid levels were independently and significantly associated with the risk of cardiovascular mortality, and there was substantial benefit in treating these patients. Now, hyperuricemia and heart failure is a very debatable topic. This study, hyperuricemia and incidental heart failure, showed that hyperuricemia was a novel independent risk factor for heart failure in a group of young general community dwellers. And not only a risk factor, as it was also proved to be a poor prognostic marker. We are all aware of the exact heart failure study, whereas allopurinol was used to improve cardiovascular mortality, but unfortunately the results did not favor allopurinol. But apart from exact heart failure, which had its own limitations, there are many studies which has been done on improvement of myocardial contractility, ejection fraction, on xanthine oxidase inhibition. The very famous LIVE study, which was conducted to prove the cardiovascular benefit of losartan over atenolol, was attributed to the uricosuric action of losartan in itself. The very much neglected peripheral arterial disease was also found to be associated in Taiwanese and Chinese population with increasing risk of hyperuricemia. Now, coming to hyperuricemia and renal disease, the main mechanism was attributed to alteration of glomerular hemodynamics and activation of the renin-angiotensin system. A very large study was conducted, a 25-year follow-up for risk factors for end-stage renal disease has proved that hyperuricemia is a novel risk factor for developing end-stage renal disease. Now, these are multiple RCTs on urate-lowering therapy in CKD, which has shown that this drug, allopurinol mainly, has slowed the progression of CKD and decreased proteinuria. 2 of studies are from India as well. Coming to acute kidney injury, hyperuricemia did not disappoint here as well. Now, the very controversial metabolic syndrome, there was also again a controversy whether hyperinsulinemia is causing hyperuricemia by preventing renal excretion of uric acid. This was answered by the Finnish diabetes prevention study, which has shown that hyperuricemia has been an independent risk factor for progression to hyperinsulinemia, which has been seen in an 11-year follow-up. The lipid profile alteration has also been seen in association with hyperuricemia, and now the very novel concept of dietary fructose intake and increasing risk of hyperuricemia, and both of these factors act as independent markers of increased risk for non-alcoholic fatty liver disease and NASH. Coming to stroke, hyperuricemia may modestly increase the risks of both stroke incidence and mortality. That has been proved in many studies and meta-analysis as well. So, if we try to follow the guidelines, you can see only the Japanese guidelines is differing from all other guidelines, ACR, EULAR, American Rheumatology Association, ACP, and literally they have outweighed the Japanese guidelines. So what do the Japanese say? They say that if serum urate is greater than 9, you go for treatment straight away without any hesitance. But if it's greater than 8 with other cardiovascular renal risk factors, you should advocate treatment. In Japan, 84 to 89% of nephrologists prefer treating asymptomatic hyperuricemia and chronic kidney disease compared to only 4% of the US nephrologists. So right now the thing is very chaotic. There is no global consensus, and hyperuricemia tends to be omnipresent everywhere. So this is the preferred guidelines for management. Only one definite indication is there, that is to prevent acute urate nephropathy in chemotherapy. Apart from that, with patients having history of kidney stones and very high levels of uric acid are being stressed upon, they have mainly stressed upon lifestyle modification first, rather giving urate lowering therapy after adequate investigations. But the science has revealed that purine-free diet is completely a myth, because majority of hyperuricemia is contributed by endogenous purine than exogenous purine. But rules are meant to be broken. This very article published in Saudi Journal of Medical Sciences showed that doctors in Makkah region depend on the level of uric acid rather than the international guidelines on treating. And an AJKD editorial has revealed and proved a valid questionnaire that when the uric acid is exceeding 9 milligram per deciliter, the risk is almost 3 times for CKD. So when shall we start treatment? So to summarize, asymptomatic hyperuricemia doesn't deserve to be ignored at this point of time. When serum uric acid is greater than 9, there is increased risk of CVD as well as CKD, chronic kidney disease. We do not have an adequate risk score like the ASCVD risk score or FRAX risk score when to initiate treatment. Lifestyle modification is the key till date, and therapy is not recommended till now except the Japanese guidelines. So moreover, with this statistical jugglery and a lot of meta-analysis, evidences, observational study I spoke about, we are standing at a point where we are not treating this condition. So I don't know whether in near future or in the long run, this masterly inactivity may harm us at all. Thank you very much for your patient hearing.
Thank you, Dr. Chakravarti. Now I will call upon Dr. Biswajit Bonik to speak against the motion.
Very good afternoon, everyone. I am Dr. Biswajit Bonik, Junior Resident, RG Medical College. Today my topic of debate is asymptomatic hyperuricemia, you should treat or not treat. And my opinion on that is asymptomatic hyperuricemia, you should not treat. So what is asymptomatic hyperuricemia? There is no universal definitions of hyperuricemia. The pathological definitions is above the 6.8 milligram per DL serum urate level, but the Japanese has defined as 7 milligram per DL in both genders and all ages. The causes of the hyperuricemia are mainly the excess purines and the hematologicals, myeloproliferative and the lymphoproliferative disorders. But the main causes found in hyperuricemia is decreased renal excretions of urate. Another spectrum of hyperuricemia is gout. Gout is nothing but excess urate crystals accumulating in the body fluids that resulting in the inflammatory arthritis. And gout is a most common inflammatory arthritis found prevalent in worldwide. So what is the burden of hyperuricemia and gout? The National Health and Examination Survey 2007 and 8, they survey the prevalence of hyperuricemia and gout in the US. The prevalence of gout is about 3.9% of the total patients, and hyperuricemia is 22% of the patients. The other prevalence of the other countries like China is 6% to 25%, in the Taiwan 10% to 52%, in the Japan 20 to 26%. In the US is morally about 22%. So what is the burden of the gout? The burden of the gout is 1/5 of the total hyperuricemia. Before going to the clinical spectrum of the gout, patients have a long-standing history of asymptomatic hyperuricemic state or asymptomatic monosodium urate crystal depositions in the joints. So why all hyperuricemic patients does not develop gout? This is an Egyptian journal and published an article that gout is an old disease with new perspective, clearly stated that 5% of the patients of hyperuricemia above 9 milligram per DL develop the gout. And according to their thoughts, the reason behind this may be the genetic factors. This published genetic wide association study published in the 2018 Lancet, the study was on normouricemic patients who develop gout. The another one study published in the last year, Annals of General Rheumatic Diseases, the genetic wide study for asymptomatic hyperuricemic patients who develop gout. The genes are only linked to ABCG2, SLC2A or SLC17. So the controversies remain persist. Why some individuals with hyperuricemia develop monosodium urate crystal depositions? Why the deposited crystals can be present without a clinically apparent inflammations? So my friend talk about the criminal nature of the uric acids, but uric acids are role as antioxidants. In humans, over the half of the antioxidant capacity of blood plasma comes from uric acid. Uric acid is a strong reactive oxygen species and peroxynitrate scavengers. This uric acid antioxidant and antioxidant paradox. Antioxidant effects of the uric acid is manifested only in the hydrophilic natures of our body fluids, that is plasma. Uric acid has positive role in beneficial role in endothelial functions, in tissue repair. Uric acid is a potent mediator of type 2 immunoresponse that is helpful in allergic asthma and in parasitic infestations. So we all know that uric acid has a beneficial role in movement disorders patients and also role in the multiple sclerosis. In the meta-analysis shows that low serum uric acid levels in the multiple sclerosis and the neuromyelitis optica. And in the Parkinson disease and in the Alzheimer's disease, the same beneficial roles have been found with uric acids. So uric acid is next role in autoimmune dermatological conditions. The pemphigus vulgaris and the oral lichen planus has the same beneficial role with uric acids. So what about the guidelines and the recommendations say? The American College of Rheumatology, the 2012 guideline did not address any pharmacological management for the asymptomatic hyperuricemia. The indication for the clear cut, for pharmacological ULT, like any patients with diagnosis of gouty arthritis present with a tophus or frequent attacks, that is more than 2 attacks per year, or CKD stage 2 or stage 2 to stage 5, or past urolithiasis. The Euler and the British Society of Rheumatology does not recommend therapy for the asymptomatic hyperuricemia. But the Japanese guidelines say differ. For the Japanese guideline, if the serum urate level is more than 8 and the complications like renal damage, ISD and metabolic syndrome are present, they have treated if more than 8. And if these complications are not present, they have treated if more than 9 milligram per DL. The Australian and the New Zealand recommendations are same as American guideline. It is a multinational evidence-based recommendations by systemic review and the expert opinion of the rheumatologist known as 3E initiative clearly states there is no significant benefit with allopurinol therapy in glomerular function rates and creatinine and proteinuria. There is another systemic review published in the Journal of Rheumatology. The pharmacological treatment for the asymptomatic hyperuricemia cannot be recommended at present for any prevention of gouty arthritis, renal disease, and CV events. So what are the known complications of hyperuricemia? Gout, urolithiasis, or acute uric acid nephropathy. So hyperuricemia beyond gout, the controversial complications. The first controversial complications is hyperuricemia with cardiovascular associations. This is enhanced study, study population 5,421 patients. Study was conducted in 1971 to 1987. This clearly shows that there is no association seen between the main patients. There is another study published in the BMJ Heart Journal, the serum urate levels and the risks of major coronary heart diseases. The urate level is not truly independent risk factors for the coronary heart disease, and related serum urate levels appears to be integral cluster of risk factors like insulin resistance syndromes, obesity, and triglycerides. This is a well-known study, Birmingham Heart Study, 6,763 patients, concluded with that the uric acid does not have a causal role in the development of coronary heart disease. This is ULT therapy and cardiovascular outcome. There are some study which studied that no difference in the heart failure or any cardiovascular outcome. This well-known study, exact heart failure study, allopurinol was given to the patients and there is no improvement in the cardiac status, exercise capacity and the quality of life of the patients. The hyperuricemia and the renal associations. The MMKD study clearly stated non-diabetic primary CKD did not support primary uric acid as independent risk factors. Other study also shows after adjustment of the confounding factors by multivenal analysis, uric acid is no longer estimated as a predictive of indicative of any CKD. These are the some studies with allopurinol and febuxostat. There is no increase in the eGFR after allopurinol or febuxostat therapy. So the allopurinol or the ULT therapy with hypertension outcome. The study was conducted with febuxostat, with allopurinol, and also this published in India that no significant change in the blood pressures. So allopurinol and the cardiovascular risk factors. It is a systemic review, cardiovascular risk factors and the comorbidities with hyperuricemia and Gauss clearly concluded that stroke incidence and the mortality was not increased with hyperuricemic patients. We all know that hyperuricemia may be linked to hyperinsulinemia, but the main cause may be insulin resistance, and the hyperinsulinemia causes urate reabsorptions in the kidney and causes hyperuricemia. So hyperuricemia could be both consequences or cause of a hyperinsulinemia in the metabolic syndrome. So as a doc, our first target is do not harm, that is primum non nocere. We all know that the branch bromaron withdraw from the market due to severe liver toxicity, and in the next coming days it may be occur with allopurinol or febuxostat. So the allopurinol is known for its cutaneous side effects, spectrum of cutaneous side effects with allopurinol. The most serious one, allopurinol induced SGS or TED. Did the study published in Rheumatology journal, and 60 to 86% patients treated for asymptomatic hyperuricemia, and the annual incidence of the allopurinol hypersensitivity is 0.5%, and the adverse effects are twice in the patient with allopurinol use for the asymptomatic hyperuricemia. And it is also concern for the dermatologist. It is published in 2016 with British Journal of Dermatology, that's severe cutaneous adverse reaction due to inappropriate medication use. And the most commonly inappropriate drugs are allopurinol. And the most common indication is asymptomatic hyperuricemia. The other side effects are recurrent meningoencephalitis, acalculous cholecystitis. And where you go to the FDA website, and for the product information, if you search the allopurinol and febuxostat indication, the first lines written is non-recommended for the treatment of asymptomatic hyperuricemia. So what about febuxostat? A couple of years ago, we know that febuxostats may be the better for the cardiovascular profile, but after curbing NEGM in the 2018 CREAS trial, has increased risk of CV death with febuxostats than with allopurinol. And in 2019, FDA adds a black box warning for the use of febuxostat. This one is 2013 by warning noticed by French National Drug Safety Agency that asymptomatic hyperuricemia does not indicate allopurinol therapy, and every effort should be made to avoid the prescribing an ULT for inappropriate indications. So what is the cause for ULT therapy for asymptomatic hyperuricemia? The Mendelian studies have failed to confirm that ULT levels with the comorbidities. The risk of benefit ratio of the ULT is not clear. No studies confirms ULT improve comorbidities. No recommendation except the Japanese. So what do we do with asymptomatic hyperuricemia? At first, the identify cause or contributing to the hyperuricemia, the lifestyle factors like alcohol consumption, obesity. So, there are non-pharmacological interventions like therapeutic lifestyle changes, avoid the strong alcoholic beverages and soft drinks, prefers low-fat carbohydrate, low-fat dietary products, limit consumption of animal protein, and weight loss and physical activity. This article by Dinsar et al. And asymptomatic hyperuricemia when you treat, because hyperuricemia is not a disease. Treatment should be restricted to the specific circumstances, and it may be receiving chemotherapy or radiotherapy, have a patient having kidney stones with recurrent uric acid nephrolithiasis, patients with history of gouty attacks, and patient having exceptionally high level of hyperuricemia. So in summary, no guidelines recommended ULT in the asymptomatic hyperuricemia except Japan guideline. Direct link with the cardiovascular and the renal comorbidities is hard to prove. Limited data on the efficacy of the non-gout diseases of the ULT drugs. Adequately powered clinical trials and clinically relevant endpoints are required, especially focusing on the CV deaths, CV and the renal. So the urate lowering therapy for the asymptomatic hyperuricemia cannot be supported at present conditions. Thank you.
So I would request Dr. Uddalok, I'll give him 2 minutes, because he dwelt primarily on the CAD aspect, while Dr. Bonik has talked on protective effects of uric acid. So he gets 2 minutes to take the challenge.
So time for rebuttal. So from my side, I have shown whether I would like to change it to rather pre-symptomatic hyperuricemia. I've shown several evidences regarding meta-analysis, observational studies, and many other studies, RCTs, which have shown conclusive evidence that hyperuricemia is linked with cardiovascular mortality, be it hypertension, be it atrial fibrillation, be it any sort of cardiovascular side effects like ischemic heart disease and all. So this masterly inactivity of not doing anything and waiting for the fire to catch you compared to using the fire extinguishing may be disastrous for us in the long run. Next, we are always looking for an independent association. Why that so? Because we are thinking that hyperuricemia will lead to CVD and it may be mediated by hypertension. This independent association may be harmful for us because many studies will miss that hyperuricemia is causing hypertension, that is causing a cardiovascular mortality. If we limit this to only the independent association, we may miss a very dependable association as well. Now, there's a lot of reasons about the discrepancies because definition of hyperuricemia can vary from study to study and differences in adjustment of certain covariates in the statistical analysis. Coming to the very famous Framingham Heart study as told by my opponent, well, most of the participants were white and this was extremely applicable to European data rather than all other data, and there were certain other limitations as well. This was the limitation of exact heart failure, which was limited to only 24 weeks for exact heart failure trial. And you have to take the CARE trial with a pinch of salt because the dropout rate was around 60%, one of the highest dropout rates in cardiovascular mortality trial. So I do not deny the fact of incidence of irrational use of urate-lowering therapy for the skin side effects. So right now, we are waiting for a paradigm shift in the change in the guidelines. And I always believe a stitch in time will save 9 actually. Thank you very much.
Okay, thank you. So, Dr. Bonik, if you have something to say, please restrict for within 2 minutes.
So, time for cerebral. According to the Japanese guideline, let's see the Japanese guideline says. In the Japanese guideline, there is some disclaimer. And then the disclaimer that shows that there are no interventional studies considering for the complications. That's the complications for the treatment of the asymptomatic hyperuricemia. And with my friend presents the RCTs. The RCTs are sample sizes like 30, 40, 45. And in the systemic review and the meta-analysis, there is some confounding factors. And this is also present in the hyperuricemia and the coronary heart disease. So this is after the CARE study, febuxostat and the cardiovascular events, the systemic review and meta-analysis. This also shows the increases of CV death with patients with gout. This is a no CKD study. It is a no CKD study is observational study. How can observational study can told that hyperuricemia and cause CKD? The discrepancy hyperuricemia is variably defined. Hyperuricemia can be cause of the consequences of the comorbidities. Observational study cannot provide proof of causality. Sample size are small and the statistical powers limited in the randomized control trials of the ULTs. So furthermore, no data exist on the potential effects of the genetic polymorphism, urate-related biological mechanisms. So we all know that in the 1980s, we believed that uric acid is an innocent bystander, watching crime from the neighbor. But in recent days, as my friend told and the many systemic review told, it is a central playmaker. So large randomized control trials are required for fixation of the primary endpoints, mainly on the CV and the renal outcomes, and ULT therapies with the focus on these comorbidities. So for this time beings, according to the recent guidelines and the recent trials, asymptomatic hyperuricemia should be recommended.
So, actually, throughout the world, everybody is running after one thing, risk reduction, residual risk reduction. So, everywhere, people are looking at the prospects. How can you reduce the risk? Is the LDL 29 the optimum? Or how far low should be the blood sugar? Or what should be the optimum level of hypertension? Naturally, in this scenario, uric acid is peeping its head somewhere. And the proponent, he has predominantly dwelt on this aspect, risk reduction. He has talked primarily on CAD, while the opponent has questioned basically the good things about why should one ignore the good things of uric acid? Having uric acid levels in your body can be protective, is a good antioxidant. Still, as far as the things go, both of them has reported two very important trials, and they have questioned those trials. One is the CARES and the no CKD. These are two important trials. And both of them has talked about the drawbacks of these two trials. So now, whether you start some therapy for uric acid for that residual risk or not goes to the audience. And may I ask, or may I request sir to ask the audience, what do they prefer or what would they like?
From the audience, those who are in favor of the motion, please.
So the proponent could not impress the audience. So those who are not in favor. Again, there is nobody? At least there is somebody. So the rest of the audience is non-committal. Thank you. So
Just one point, my personal impression, asymptomatic hyperuricemia should not be treated unless in special circumstance, like...
That is the point is important. Now what you have said, sir, that is the point. The asymptomatic hyperuricemia should not treat, but the caption is should not treat by urate lowering drugs. It is not written. It is written asymptomatic hyperuricemia should not treat. That is not correct, but it should be treated. It should be observed. It should be the cause to be detected. Which is the cause? Is it some metabolic cause, or is it some myeloproliferative disease, or is it a renal failure? So you have to assess which is the cause. If the cause is known, then it is okay. You have to treat. Strong, and if it is not, then you should not be treated till date. That is written, and he has mentioned. But Japanese has changed these guidelines, and if it is go to that, and that is a main point. So we have to think of ourselves. That's why debate is given here. That we should be changed, because as the ASEAN has already changed it. Should I change in our guidelines in the lowering, at the lower level? That is the main.
So that is your debate is may be treated, not be treated, may be treated or may not be treated. So that is the debate. So it cannot be a debate then. Thank you very much. So I think it should be closed by this way. Thank you.
so the next, so for the next debate, the motion is first injectable in T2DM patient management should be GLP analog and not insulin. May I request Dr. Sharmishta Mukherjee? I think she has the world with her. And the opponent, Rana Bhattacharya.
Respected Chairperson, sirs, and dear friends, my debate topic today is fast injectable in type 2 diabetes management should be GLP-1 analog and not insulin. Now, before establishing GLP-1 analog as the most ideal agent as anti-diabetic for fast injection, I should first narrate what is one ideal anti-diabetic agent is. An ideal anti-diabetic agent should be very efficacious, particularly in lowering HbA1c. It should have minimum hypoglycemia risk. Ease of administration should be there, that it should be very patient friendly. It should have favorable effect on body weight, favorable effect on lipid profile and blood pressure lowering, favorable cardiovascular outcome, some action on renal protection. There should be minimum other side effects, and safety profile should be good. And last but not the least, the cost of therapy should be reasonable. Now, with these points keeping in mind, we should see here how far GLP-1 receptor agonist fulfills the criteria of being ideal fast injectable anti-diabetic. Now the tools used here are mainly the meta-analysis, and I have purposefully kept those meta-analyses where there are head-to-head comparison trials with insulin, keeping aside those who have less with placebo, with analysis with comparison with placebos, also the systematic reviews, the review articles, the original articles, mainly the recent CVOTs, and of course the scientific logics. Now regarding the efficacy, a meta-analysis comparing the clinical effects of short or long-acting GLP-1 receptor agonists versus insulin treatment from head-to-head studies in type 2 diabetic patients. 16 studies were compared in these, and all the landmark and semi-landmark studies which showed that GLP-1 receptor and insulin on a background of oral glucose-lowering medications. 13 studies compared with basal insulin and 3 studies with premixed insulin. And clearly it has been shown the short-acting one, the green ones, and the long-acting are the blue ones. It has been seen that in short-acting GLP-1 receptor agonists versus insulin, there is almost similar glucose-lowering effect. But for long-acting GLP-1 receptor agonists versus insulin, and also overall result, GLP-1 receptor agonist has greater HbA1c lowering effect in comparison to insulin. Now, coming to the second point, that is hypoglycemia risk. In the meta-analysis, more than one hypoglycemic episodes, if it has been seen, for any hypoglycemia, the short-acting, long-acting, and all GLP-1 agonists have shown significant advantage of GLP-1 receptor agonists versus insulin. For nocturnal hypoglycemia, also the same. And for severe hypoglycemia, only the short-acting insulin has shown significant less hypoglycemia risk in comparison to insulin, although not for long or overall GLP-1 receptor agonists. Now, an interesting observation is that the episodes which appear to be, these hypoglycemic episodes for GLP-1 receptor agonists appear to be confined mainly to those patients who have sulfonylureas as their part of background glucose-lowering medication, as seen in this duration 3 trial. And another interesting fact is that this risk of hypoglycemia is greater when hypoglycemias are combined with basal insulin rather than GLP-1 receptor agonists. Now coming to the patient-friendly approach. When adherence to anti-hyperglycemic medications and GLP-1 agonist, receptor agonists have been seen in a systematic review of 36 studies, it has been seen that the barrier to adherence mainly is due to regimen complexity, dose frequency, formulation and injection devices, and fear of side effects. Now, you can see in insulin, when basal insulin is used, it addresses mainly the fasting hyperglycemia mainly, and if postprandial hyperglycemia is there, then additional use of rapid-acting or short-acting insulins should be given, needing multiple pricks. But for GLP-1 receptor agonists, we have choice of agents. If we have fasting hyperglycemia, we can use this long-acting GLP-1 array. If there is postprandial hyperglycemia, we can give a single shot of short-acting GLP-1 array, and it depends on the type of hyperglycemia, thus decreasing the number of pricks. Again, the minimum frequency of dosing of insulin is once daily, if one basal insulin is used, but we have once weekly preparation in GLP-1 receptor agonist, thus definitely it is convenient for the patients. Over and above that, for the fear of hypoglycemia, the insulin-taking patients must have multiple pricks for SMBG, whereas for GLP-1 receptor agonist, SMBG is not mandatory as the hypoglycemia risk is minimum. Now, for patient preferences, there is a review of 10 studies which compared different GLP-1 receptor agonists versus glargine. And there are 19 attributes which showed 10 process-related and 9 outcome-related attributes. Most commonly evaluated process attribute was dose frequency, which was found in 8 studies, that is in 41% 6 patients, that the patient preference is there when there is less dose frequency. And it has been clearly mentioned there that GLP-1 receptor agonist profiles with fewer injection are preferred by the patients. Now regarding the body weight, for short-acting, long-acting and all GLP-1 receptor agonists, the mean difference versus insulin is minus 3.7 3.6 kg, which is statistically significant. And when the weight loss is the primary outcome rather than HbA1c reduction, 25 trials were including in a systematic review and meta-analysis, and it has been shown that GLP-1 receptor agonist group achieved a greater weight loss than control groups with a mean difference of 2.9 kg in a heterogeneous group, but larger difference, almost a double, was there when the comparator was insulin. Now, same thing about the blood pressure. Both short-acting, long-acting, and all GLP-1 receptor agonists have been seen in the meta-analysis to reduce significant lowering of blood pressure. For lipid profile, the triglyceride lowering effect of GLP-1 receptor agonist versus insulin is also statistically significant and mostly observed in long-acting GLP-1 receptor agonist. Now, coming to the cardiovascular outcome trials, all of you are conversant with these three leading trials, the LEADER, SUSTAIN 6, and recently published REWIND trials, which dealt with liraglutide, semaglutide, and dulaglutide, and which showed that these things, when 3-point MACE, CV death, non-fatal MI, or non-fatal stroke have been considered, is not only non-inferior to the placebo, but also it is superior in reducing this CV death and in 3-point MACE. And all other GLP-1 receptor agonists, although not superior, but they also showed non-inferiority. Now, renal outcome, it is less studied in comparison to SGLT2 inhibitors, but still in AWARD 7 it has clearly shown that insulin glargine, when compared to GLP-1 receptor agonists, GLP-1 receptor agonists have higher EGFR and also lower urinary ACR. And also one meta-analysis showed in 113 trials that there is significant reduction of nephropathy in case of GLP-1 receptor agonist in comparison to heterogeneous comparators. Now, regarding the side effects and safety profile, definitely GI side effects are the most troublesome side effects with GLP-1 analogs. A Cochrane database systematic review showed that GLP-1 receptor agonists compared with placebo or active comparator experienced nausea in 8 to 40%, diarrhea in 3 to 180% in different studies, but there is a but that nausea may wane with duration of therapy and can be reduced with dose titration. Change of agent may also reduce nausea because exenatide once weekly causes less nausea than exenatide twice weekly. Liraglutide causes less nausea than exenatide, and who doesn't know that metformin, which is the first line drug, also causes different GI side effects, but still this is the first line drug. So regarding pancreatitis also, the randomized trials have shown 55 RCTs and 5 observational studies over 33,000 patients have showed that pancreatitis occurred only in 37 patients. That rules out the association of pancreatitis with incretin-based therapies, and pancreatic safety of incretin-based drugs have been assessed by FDA and EMA, and they have given a clean sheet. Now, coming to the cost of therapy, certain points to be remembered regarding the cost of therapy. The cost of treatment includes not only the cost of drugs, but it also includes costs related to SMBG, costs related to hospitalization for hypoglycemia. There are subset of patients who can afford cost. There are subset of patients where government provides the treatment facility, and there are subset of patients where drugs treatment has been reimbursed by his or her employers. And so, coming to this, you can see here that severe hypoglycemia has a huge cost, huge burden of cost due to hospitalization. Similarly, SMBG also caused annual SMBG costs in a US study showed 24.5% of total insulin cost, which is actually 1/4 of the cost. So these are the invisible costs, and in diabetes care, this observation has been shown that the cost of self-monitoring of blood glucose is an important factor limiting glycemic control in diabetic patients, which is absolutely needed in insulin and not in GLP-1 receptor. And this is proved in Indian study also, where it is in North India it has been concluded that adhering to SMBG appears to be expensive for an Indian patient. Patient preferences, which has, when it is seen in different studies, the willing to pay for liraglutide an extra 3.36 euro per day has been seen when some questionnaires are given to the patients. Now coming to the pathophysiology, this should come at first, but I have kept in last. We all know that type 2 diabetes is not an disease of insulin deficiency, rather it has a multifactorial etiology with ominous octet, and you can see here that GLP-1 receptor agonist addresses at least 7 out of 8 of the ominous octet, and so it is definitely more and more physiological than the insulin. Now the effect of incretin-based therapies on beta cells, we all know that insulin causes beta cell preservation, but regarding beta cell neogenesis, we have only these incretin-based therapies which may cause neogenesis and apoptosis and less apoptosis, at least in animal model, and maybe later in human beings also. So if you if you keep a scoring system from 0 to 2, then you can see here that if you are very liberal to the insulin and if you are very miser to GLP-1 receptor agonist, then also the points of GLP-1 receptor agonist is at least double. So this is an unequal fight. Insulin is totally knocked out, and we are definitely respectful to our heritage, but we know that bullock carts are our heritage, but we want to fly by jet plane. We know that our childhood is reminded when telephone rings, but we use multi-purpose modern, these Android telephones. Similarly, we are respectful to our heritage of insulin. It is our glorious past, but we should accept the reality today, the GLP-1 receptor agonist, and it has been accepted. For years together, the ADA guideline was insulin-centric. It was first initiation of basal insulin followed by GLP-1 receptor agonist, and now it has been GLP-1 receptor centric, because for ASCVD, for CKD, where SGLT2 inhibitors are not given, and for these obese patients, for hypoglycemia prone patients, everywhere GLP-1 receptor agonist has been the first priority, and insulin is for a minority of patients where cost is an issue. So recommendation has already given in 2019 in ADA guidelines that in most patients who need the greater glucose lowering effect of an injectable medication, glucagon like peptide 1 receptor agonists have the preferred insulin. So friends, what is the right choice actually? This depends on your mindset, your attitude, your acceptability to the newer things. If you are very much faithful towards the veteran and old, then you may choose this insulin. And if you are really very much interested to accept the newer ones, the dynamic, the modern, and the multifaceted one, then the choice is yours, which one you have to choose. Thank you very much for patient hearing.
Thank you, Dr. Mukherjee. Now I call upon Dr. Anna Bhattacharya to speak against the motion.
A very good afternoon to all of you. It's at the outset, I must say, it's very difficult to debate with someone so amicable like our beloved Didi. But anyway, the topic is such. I mean, the first injectable in type 2 diabetes patient management should be GLP-1 analog, not insulin. Is it true? Of course not. Of course not. Why? Let's start with efficacy. Well, as we all know, the insulin efficacy is limitless. There is no bounds where you can increase the dose. Although some RCTs, as my the opponent has shown, that showed the better A1C reduction with GLP-1 analog. But if you look closely, if you look at the not even the finer prints, rather the discussion of the 3 major studies that she has described, that is LEAD, SUSTAIN, and AVARD. All these studies, just look what they have said. The first one, LEAD, said the difference between A1C reduction, the clinical significance is uncertain. The second one said that there is inadequate titration with insulin. And the third study again said the same thing. The strict reinforcement of insulin titration was not accomplished. So, see, in a randomized control trial, insulin, if you do not titrate it adequately, of course it cannot control blood glucose. That's quite obvious. So, if you would have the blood control would have been better. They have themselves admitted in all 3 major trials where there is head-to-head comparison between these 2 agents. There is another aspect. Say, for the matter of debate, if we can accept the GLP-1 agonist as a very good A1C reduction in RCTs. But what happens in real life? If you look at this recent trial published in Diabetes Care, there is a huge difference between real life and in the context of RCTs. The A1C reduction was more than 1%, whereas in real life, it's just half. What's the reason behind that? One of the major cause, of course, is non-compliance with GLP-1 analog. I'll come to those later on. Regarding durability, as we all know, with time, all oral anti-diabetic drugs are bound to fail. Whatever beta cell preservation data is there, it's not on human model, it's on animal model, and data are very preliminary. But insulin has infinite durability. So of course it should be the first choice for injectable. Regarding safety, first, of course, I'll start where the GLP-1 agonist has so-called brownie point, that is CV safety. Now, there is some apparent CV benefit with GLP-1 analogs, but please remember, those studies were conducted in a patient only with high CV risk. Now, how many of our patients, the day-to-day patients, have such a high CV risk? Practically very minimum. So, of course, if you use such a costly agent with so much other costs, which I will tell, this is not suitable as a first-line agent. Regarding insulins, older insulin, of course, there is no need to CV safety data, but with newer insulins, there are good CV safety data, and they are absolutely cardiovascular safe, even in a patient with high CV risk. Now, talking about hypoglycemia. My learned opponent has said that hypoglycemia is not there with GLP-1 analog, but there with insulin. But let's see one of the trial, that is lead 5. The same trial that she mentioned, it is seen that 5 patients reported major hypoglycemic event in GLP-1 group, whereas no major event was reported in insulin group. That's in the same RCT, right? So hypoglycemia, the result is very much variable. Other aspect, GI symptoms is very, very, very common. There are elevation of amylase and lipase in most of the studies. Although the potential for pancreatitis is uncertain, but the studies are not of duration longer enough, it's not there, not long enough to actually demonstrate the risk of pancreatitis or pancreatic cancer. But the concern should be there whenever there is elevation of amylase and lipase. There is definitely more local reaction with GLP-1 analog than insulin. There is increased chance of cholelithiasis and increased risk of retinopathy as shown with the recent 2 major trials. So let's not talk all about the macrovascular outcome. We have to look at the microvascular one as well. Regarding compliance, it's one of the very important aspects when we consider a day-to-day therapy for a particular patient. And in all randomized controlled trials, the discontinuation rate is much more common with GLP-1 analog than insulin. Now, you know, in a RCT, there is close monitoring, close guidance of the patient. But in real life, if patient experiences GI symptoms and other symptoms, and with such a cost, the patient may not come back to you for report. So naturally, the discontinuation rate will be much higher. So of course, the first choice of injectable should be insulin. Now coming to cost. If we consider the cheapest GLP-1 analog that is available to us now, the cost is around 7,000 rupee a month. Let's consider the costliest human NPH insulin that's available to us. The monthly cost is rupees 400. Okay, you say you don't want to use NPH, you want to use glargine, which is the state of art. The costliest glargine available in the Indian market, If we use 20 units per day, which is adequate dose for most of the patients, many patients require even lower dose, the cost is around 1300 rupee per month. So obviously, if you compare rupees 400, rupees 1300, I am giving the costliest brands. So with that, if you compare the cheapest brand of GLP-1 analog, it's much, much higher. Even the guidelines which my opponent quoted, where the GLP-1 analog is preferred, if you look closely, the insulin should be considered as fast injectable, even if patient can afford. Remember this, that when the A1C is very high at presentation, there is symptomatic or there are symptoms of diabetes as well as catabolic features. And when type 1 diabetes is a possibility. Now, when patient presents to you, you are not sure what type of diabetes is there in many of the patients. And not only in type 1, if we look beyond type 1, which is very common in our country, that is pancreatitis-related diabetes. FCPD is very, very common in our country. So there, GLP-1 analog would be contraindicated. So before testing for all those things as a fast injectable, in a newly detected diabetes, I would rather hesitate to use this class of drug. Now, another aspect of the guideline, they clearly said if cost is a major issue, then of course insulin therapy should be preferred with lowest acquisition cost. Now, you can say the cost is a very arbitrary factor. Say if I am asked to use an injection of 7,000 rupees a month, I am calling the cheapest. The costliest one is 10,000 rupee a month. I mean, more than 90% patient would be poor in this respect if we ask the patient to choose between these therapies. So, of course, the cost is important. And other guidelines also support this nation. Besides that, with all this, are we forgetting something? In all those randomized controlled trials, the OADs which are used are metformin and sulfonylureas. So what we use in our real life? With metformin, sulfonylurea, we use SGLT2 inhibitor, we use GLP-1 analog, we use DP4 inhibitors. On top of that, we add insulin. But that is not tested in any of this trial. Of course, the benefit of insulin would have been higher if these OADs are used, which we use in our day-to-day clinical practice. So GLP-1 analog should not be the fast injectable in this instance. And if you use GLP-1 analog, obviously you cannot use DP4 inhibitors. But if you use insulin, you can use DP4 inhibitors. This is not tested in these trials. Now, besides this, if you look at the future, the topic was the first injectable should be GLP-1 analog. Now, very interestingly, even if you want to use GLP-1 analog, recently FDA has approved oral semaglutide. So when this is available in our country, obviously all will use this kind of drug rather than the injectable one. And then also, my opponent has talked about the future. Then also in future, if you have an oral GLP-1 analog, do you use injectable? Of course not. You will use oral GLP-1 analog and you will use insulin, basal insulin along with that. So insulin would be first injectable even in those instances if you want to use GLP-1 analog, right? So to conclude, insulin is the most efficacious therapy available to us. The side effect profile is better. Adherence is better. It's much, much cheaper even if you take into consideration the cost of SMBG. Weight is not an issue for most of the patients who come to us. And oral GLP-1, as I have said, will replace injectable, so insulin would be automatic choice for fast injectable therapy. So if you talk about guidelines only, as the famous First World War ace, Douglas Bader said that rules are for the obedience of fools and the guidance for wise. And as I know, my opponent is at least 1,000 times wiser than me. She knows herself that of course insulin is a better choice, but of course she has no choice because this is a debate. So of course the first injectable therapy in type 2 diabetes should be insulin, not GLP-1 analog. Thank you for your patient hearing.
Thank you, Dr. Bhattacharya. Now I call upon Dr. Mukherjee to say her points.
Thank you, Rana, for your excellent deliberation, but I have certain points to retaliate. First of all, you have told that insulin has got highest efficacy. Yes, but efficacy should always be balanced with the side effects. If you maximize the dose of insulin, as you have told, that it has got infinite potentiality because there is no maximum dose of insulin, don't you think that maximum dose of insulin will produce maximum hypoglycemic effect? You have described one trial that there were certain few incidences of hypoglycemia with liraglutide. But all of us know that this is only exception, but for insulin it is almost rule, because whenever we prescribe insulin for a patient, we always tell them that the hypoglycemia will be the part and parcel of your life, and you should not be afraid of that fact. We should combat it. Secondly, Dr. Bhattacharya has already told that in few trials, it has been proved that it worsens, GLP-1 receptor agonist worsens the retinopathy. But in SUSTAIN 6 trials, it has already, several articles have been written over it, that the patients who was suffering from retinopathy, in those subset of patients, actually they were of long duration patients, and they had higher HbA1c, so they were suffering from retinopathy, not due to a GLP-1 analog itself. Cost. He has already mentioned the comparable cost. I think I have already shown that cost doesn't mean the cost of the drug only, but cost means the cost of monitoring, the cost of hypoglycemia due to hospitalization due to hypoglycemia, and of course, the cost may be afforded by many. So for those subset of patients who can afford, why shouldn't we go for the best drug? And recently, AACE trial also, not only ADA, but AACE trial have also told that there should be no choice among the best drug and the cheapest drug. Best drug should always be given first, cheapest drug should be considered later. Thank you.
Dr. Bhattacharya, please.
Regarding hypoglycemia again, you all know that with basal insulin, if we titrate properly and make proper patient education, the hypoglycemia incidence is very, very less. As shown in multiple meta-analysis vis-a-vis GLP-1 analog, the hypoglycemia incidence is not more. Even as I've said, in one GLP-1 analog study, the hypoglycemia is severe hypoglycemia is even more than insulin. Regarding second point, the insulin-induced hypoglycemia is of course much less with basal insulin. Whatever hypoglycemia you talk about, the more chance is with premixed and prandial. But all these studies are with basal insulin, what we use as a first injectable in most of the instances. So there insulin should be preferred. Regarding the health economics, as I've said, that if a drug costs ₹700, now it's very difficult to differentiate between rich and poor. Because most of the individuals who are apparently middle class, apparently higher middle class, will find it difficult to afford a drug which costs around 10,000 rupees a month, along with the all other medicines they are having. So such a high cost of therapy, most of the household cannot afford this. So cost is very, very important, because in India it's not, US or not like UK or others, where here the patients, they use drug with out-of-pocket expenses. So naturally, they won't take these drugs long. And that's all our practical kind of experience. Regarding regarding the safety aspect, again, as I will reiterate, that the duration with the GLP-1 analog therapies, the trial durations are relatively lesser. We do not know about the long-term safety. Whereas with insulin, we have multiple trial, very long experience with long-term safety profile of these drugs. So of course, I will reiterate that insulin should be the treatment of choice as a first injectable. Thank you all.
Thank you so much. So it now goes to the audience. If there is anyone to make a comment on this, On one side, it's hypoglycemia, the other side, safety and efficacy. One side, it's tradition, the other side is probably Chandrayaan 2. So, with anybody else to comment, make a comment on this very delicate issue. So, do we go for a voting? So, how many would like to start, irrespective of the cost, with GLP-1 analog? So, we have somebody. So, should I take it that the rest of the audience will go for insulin? So none of them talked about cancer. Anyway. Cholangiocarcinoma. One published BMJ this year. So thank you. With that, we close this session. And I think we go for the next session.
So the debaters should come in the dais, and I will request the chairperson to give them the memento. अपने चेयरपर्सन को दिए दें, give memento to the chairpersons. I request Professor T.N. Ghosh to give the memento to the chairpersons. একই সঙ্গে চেয়ারপারসনদের হয়ে যাক, একসঙ্গে ছবি হয়ে যাক। সবাই নিয়ে নিক হাতে ওটা। রানা